Uh, Today we have a patient who is 39-year-old female patient. She is a homemaker. She is right-handed and informant is self and she is reliable. She gave me multiple complaints. Her problem started with headache since 15 years and inability to perceive pain in both the forearms and hands, which happened since 11 years, and difficulty to lift the utensils from the stove or the table since 3 years. After that, she had difficulty to perceive hot and cold sensations. Sorry for the spelling mistake, ma'am. Hot and cold sensations in both forearm and hands since 2 years. Inability to perceive clothes, bangles over forearm and hands since 2 years. She had noticed that a change in the shape of her hands and fingers since 1 year. And after that, her lower limb problems started since 1 year. She had difficulty to stand up from squatting position since 1 year. And she had swaying to the left side while walking since 1 year. Following this, she had a history of passing urine in small quantities, which has increased in the frequency since last 1 year. And she's passing hard stools once in 2 to 3 days since 1 year.
Okay. Okay, ma'am.
So history begins from 2009. Patient was apparently normal 15 years ago. She developed headache. Headache was of dull, aching nature of pain, and it was predominantly in the frontal region and the nuchal region. It was associated with nausea. It was associated with painful neck movements. And important history she gave was it was increasing with cough and sneezing. So for this, she took over-the-counter medications for first 10 years. She did not show anywhere.
Was the headache present every day?
Yes, ma'am.
Every day?
Yes, ma'am.
So would you like to analyze that headache?
Ma'am, dull aching nature of headache, especially tussive headache, which is increasing on coughing, suggests that the pathology could be due to raised ICT. Usually this type of headache is common in the early morning hours, but patient did not give any such history. She said it was persistent throughout the day. This pain predominantly in the neck region and it is increasing with coughing. I would like to think of a pathology somewhere either in the bony pathology or else it should be an intracerebral like cystic lesion of the brain.
Okay. Why cystic lesion you thought?
A tussive headache is usually seen in such conditions, ma'am, where there's a communication with.
What kind of cyst you are keeping in your mind?
Arnold-Chiari malformation.
That is not cyst, no? So first, if you want to analyze a headache, so
yes,
your patient is having a long duration headache or a short duration headache?
Long duration
headache.
Yes, ma'am.
So long duration headache means what are the situations? Forget about whatever diagnosis comes later.
Yes,
so this particular symptom we'll analyze. So it's a long duration headache. In a patient with long duration headache, when will you think of raised intracranial pressure?
Early morning headache.
Any headache which is more than 1 year duration is long duration. Yes. Short duration is less than 1 year and days to months is ultra short. That is how it is. So long duration headaches are usually benign headaches. Because long duration, nothing happens to the patient. So it cannot be ICP. It is very simple. But long duration headache in a patient happening with a recent change in the character, because your patient with long duration headache can also get new complications. So in this patient, it is a long duration headache and we are not aware of any recent change in the character. The character remains constant. You see, so that way this headache is less likely to be due to raised intracranial pressure. Even if you have found some intracranial pressure on examination investigations, it does not matter. But no ICP will remain like that. without producing any blindness or projectile vomiting and rapid deterioration. That did not happen. So this is a
Yes.
long duration headache. And with whatever history we have, it is dull aching in nature.
Yes, sir.
Whereas what is the nature of a headache? Dull aching headaches are usually muscle contraction headaches. They are not ICP headaches. You see, supposing you have got a examination coming and you are putting so much strain on your occipitofrontalis. So the occipital belly and the frontal belly will contract. So this muscle contraction will produce a frontal headache and an occipital headache. This patient is having a frontal headache and an occipital headache. But because the occipitofrontalis is attached to the vertex.
Yes.
So when an tension type of headache due to a constant stress in a family initially starts with an occipitofrontal headache. Later, the headache will be experienced over the vertex because it is the attachment of the occipital belly and the frontal belly. So that did not happen. So your patient had a headache in the frontal region and an occipital region, but the headache later, even though it lasted for 15 years. So 15 years of continuous contraction of occipital and frontal belly of occipitofrontal is due to a constant stress environment. For example, you are working in bonded labor or working in another country where you are almost or worse than a bonded labor. You are contained by your Aadhaar card and other things. Many people suffer like that. So those kind of things, the headaches later shifts to the vertex. Because constantly the pain is getting pulled from the insertion of the occipitofrontalis. So that did not happen. So I always tell you have got hard signs, you have got soft signs, and you have got odd signs. So odd signs for this occipitofrontal headache is there is no shifting to vertex.
Yes.
That means this occipitofrontal headache is probably not due to constant contraction of frontal and occipital belly of the occipitofrontalis. That will definitely produce shifting the pain to the vertex. That did not happen. So you will pick up the odd sign from the first. So what are the other things where you can have a headache in the frontal region and the nuchal region? What is the next type of headache you can get? The frontal region and the nuchal region. Chronic migraine headache itself can do. So why does a migraine headache go to the neck? So long duration headache, no? So why it is not migraine? Like we picked up, it is not tension headache. It is not due to occipitofrontalis. Like that, why it is not migraine? Why the migraine headache goes to the neck? You have got the spinal nucleus of trigeminal nerve. See, it's a sensory nucleus. That is called, actually migraine headache, the neural mechanisms are trigeminal-vascular. It is the trigeminal branches which are supplying the branches of the intravascular compartments. So vascular headache is vascular phenomena, but the neural mechanism sensing pain is the trigeminal-vascular connection. And the trigeminal nerve has got a mesencephalic nucleus, chief sensory nucleus, and the spinal nucleus. The spinal nucleus is the pain sensitive one. Mesencephalic nucleus is proprioceptive, and chief sensory nucleus is touch. So the severe type of pain is mediated through the spinal component of the trigeminal nucleus, which supplies the vasculature. So the pain will be in the neck. Next time when you see a migraine patient, you ask, do they have a headache in the neck? Most of them have. That's called a trigeminal-vascular reference. So can it be a migraine headache? Then the odd point is, so it can be neck, it can be frontal region. But the odd point is, usually the vascular headaches are unilateral. And they alternate. So unilateral alternating. You said some nausea. That is okay for a migraine headache. So unilateral alternating headache with or without aura. Aura may be fortification spectra, block spots, migrating images. No? What is that called? What you get all those spectra? It is all called spreading depression of Leo, L-E-O. Because migraine is a minor form of seizure like electrical discharge in the brain. So there is a spreading depression of function. This is followed by vasodilatation. This depression of function in the occipitotemporal region is the one which produces the aura of classical migraine. And that spreading depression of function is spreading at the latency of about 3 millimeter per second. You can time the movement of the tecopsias. No? So it is unilateral, alternating with or without aura. If aura is there, it is very good. If aura is there, you call it as classical migraine. If aura is not there, also no problem. They are called common migraine. So classical migraine, common migraine, complicated migraine, and migraine without headache. This is the bedside classification. Research classification is different. International research classification is for research purpose. Otherwise, bedside classification is common migraine, classical migraine, complicated migraine, and migraine without headache. So common migraine is no aura, unilateral alternating, not dull aching pulsatile headache, whose frequency is usually 3 to 4 per month. There can be definite triggers. Nausea, vomiting can precede. That is the common migraine. Classical migraine will have the aura. It will also have the postictal fatigue, tiredness, nausea, mood change, everything. So that is the classical. Classical has 3 phases: the aura phase, the ictal phase, and the postictal phase. Complicated migraine is ophthalmoplegic migraine, hemiplegic migraine. All those things are complicated migraine. Whereas migraine without headache is episodic vomiting, cyclical vomiting. You do all the investigations, everything is negative. That's all exclusion diagnosis. Cyclical vomiting, cyclical coma, cyclical abdominal pain, cyclical psychosis, which cannot be explained by psychomotor seizures. No? So these are all migraine without headache, but that is an exclusion diagnosis. So in this case, even though occipital and frontal is well described, the unusual features are it is there daily. Migraine doesn't come daily. So in a patient who has a classical features of migraine, if it comes daily, what you will think? Long duration, daily. No? That is called a transformed migraine. Because headache, commonly all of us will face in our life. It is usually a transformed migraine. What is a transformed migraine? When you have migraine headache, classical migraine headache, you go and take a tablet, analgesic. Once you take an analgesic, the headache is relieved. But once the headache is relieved, analgesic effect goes off. After several days of analgesic use, you have an analgesic withdrawal syndrome. So that is called a transformed migraine. Yeah, my classical migraine, which comes 4 times in a month, you convert it into a daily headache by analgesic abuse. So that is one mechanism where a migraine, classical migraine can become a daily headache. Second mechanism is tension vascular headache. If you have a migraine headache and you have a tension headache, a combination of tension and migraine, that is what you write TVH, tension vascular headache. Say classical migraine headache might start, patient keeps on thinking I'm having brain tumor. In spite of repeated imaging, he is not convinced. Then a tension element gets added, that becomes a daily headache. That is a second time. Then you have got some headaches which are chronic daily headaches. So these are the things. But the point against migraine is a daily, but the daily phenomena is not applicable. In this case, whether did she use analgesic, we don't know. Second thing, even though it was frontal and nuchal, other features of migraine was not there. It is not unilateral, it is not alternating, it is not infrequent. So it is daily. So even though only the location can favor a migraine headache, other features are not favoring. So what is the next group of headache which can be nuchal and frontal? Second, again, you apply the trigeminal vascular reference. So what is the cutaneous supply of the trigeminal nerve? You have got an ophthalmic division, you have got a maxillary division, you have got a mandibular division. Ophthalmic division is supplying this area. And maxillary division is this to this. Below that is mandibular division. And sparing the angle of the mandible, which is supplied by the ansa cervical. So that is the cutaneous representation of the maxillary trigeminal nerve. And intracranially, trigeminal nerve supplies the vasculature. All the structures are supplied by the trigeminal nerve only. One is the trigeminal vascular. I said that is the migraine reference. Second, tendorium. There is a structure called tendorium. It separates the supratentorial and the infratentorial compartment.
Yes.
Who is supplying the tendorium? Trigeminal.
Trigeminal.
No? So supposing you get a frontal headache, it is a referred pain. A tendorial lesion, referred pain comes from a pathology in a region which shares the sensation with another region where the pathology is really not there. So you have a supply to the tendorium by the trigeminal nerve, but the same trigeminal nerve supplies the frontal region, maxillary region, and the mandibular. That is a tendorial reference. That is called tendorial reference. If you have a posterior fossa pathology, if you have cerebellar pathology, so what you told, cyst, suppose you have got a dandy walker cyst. As you said, if you are Arnold-Chiari malformation, cerebellar astrocytoma, CP angle tumors, no? All of them can produce a frontal headache and an occipital headache because the tendorium shares the trigeminal supply with the frontal region. So that is infratendorial tumors. So first is occipitofrontalis, points against we thought about. Second is vascular headache, points against we thought about. Next is the infratendorial lesions by the tendorio trigeminal reference. Tendorium is supplied by the trigeminal nerve and it refers to the frontal region. So posterior fossa lesions, whatever may be the lesion, it can be a mass lesion, it can be dandy-walker cyst, it can be Arnold-Chiari malformation. All of them can produce a frontal headache because the tendorium and the cerebellum shares the same headache. So what will be the nature of that headache? That headache can be due to raised intracranial pressure if it is due to a huge tumor. Supposing there is a cerebellar astrocytoma, you can have a frontal headache. The headache may be a trigeminal tendorio trigeminal reference headache, that will be a dull headache. If the headache is due to a shared supply and the referred pain, it will be a dull headache. And the dull headache will be in the neck also. But if that headache is complicated by raised intracranial pressure, then the ICP changes will come. So in your patient, at this point of time, there is no ICP changes. So any infratendorial lesion can be chronic. What are many of the things, including dandy-walker cyst, you told posterior fossa cyst, all of them can be long duration. They produce a long duration dull aching pain. Dull aching, it will be daily because the lesion is there every day. And every day tendorium is supplied with the trigeminal nerve. And every day trigeminal nerve is supplying the face also. So it will be there constant. So constant pathology, which is abutting on the tendorium, whatever it may be. But it is not space occupying, not producing, no, it may be space occupying, but it does not raise the intracranial pressure. Because the classical ICP features are not there. ICP features, as you said, short duration. So now 15 years headache. If this patient suddenly gets a new headache on this, so short duration headache, change in the previous character, amaurosis fugax, papilledema comes. So whenever the patient moves the head, you get a transient blurring. Two things, all the more in posterior fossa lesions, amaurosis fugax is common because the posterior cerebral artery lies on the tendorium. When you move your head, the posterior cerebral artery gets stretched and it produces occipital ischemia because the tendorial incisura is very small. So, and there is no space for the posterior cerebral artery to protect itself. It gets stretched on the tendorium. That is one mechanism. Second, it is said when you move your head, the retinal edema shifts in between the retinal layers. That also produces amaurosis fugax. So, short duration headache, amaurosis fugax, nocturnal worsening. It is not a dull, continuous pain. It will wake up the patient in the early morning and midnight when the REM sleep is coming. NREM is the sleep onset normally. We fall asleep with non-rapid eye movement and we wake up with a rapid eye movement sleep. And when you, in the middle of the night also, you have an REM. After NREM 1, 2, 3, 4, next comes the REM. After that again NREM and then the REM comes. So any time the REM is coming, there's a natural intracranial pressure fluctuation. So if the patient is already having a raised intracranial pressure, it decompensates with the natural fluctuation of intracranial pressure in REM sleep. So nocturnal awakening and early morning awakening. Amaurosis is fugax. And vomiting is, why you get vomiting in raised intracranial pressure? You know, you have got area postrema, you have got chemoreceptor trigger zone, which induce vomiting. The center which is involved in vomiting in ICP is area postrema. So why area postrema produces vomiting? Is in nature is the best defense. When there is a right intracranial pressure, we give mannitol. What does the mannitol do? It extracts the fluid and produces diuresis.
Yes.
So when there is a pressure rising, autoregulation is getting hampered, brain senses it, and area postrema is the pressure sensitive area. So it senses the brain's pressure is rising, what can I do? And it tries to eliminate fluid by vomiting. So it is nature's mannitol. So vomiting is nature's mannitol, eliminates fluid and tries to reduce the intracranial pressures. That is why you get vomiting in. You get projectile because chemoreceptor trigger zone is not affected. So there is no nausea. It is just vomiting. Nausea comes only when the chemoreceptor trigger zone is affected. So that will produce projectile vomiting. Double vision. Double vision as a false localizing sign. So none of those things are there in this patient. So even though we think that there is probably a tentorial pathology which can produce a constant dull aching, neck pain and the frontal pain, but other features of ICP is not there. And you said that the pain increases with coughing and sneezing. Even vascular headache will increase with coughing and sneezing. All of us would have had migraine at least once in our lifetime. And during the peak of your headache, if you cough or sneeze, the headache become very difficult to tolerate. That Valsalva maneuver, Valsalva effect definitely increases the intracranial pressure. And that intracranial pressure not always produces headache due to decompensation of ICP. Any hemodynamic alteration altering the dynamics inside the brain. Vascular character headache also, pressure dynamics changes when you do Valsalva. So that Valsalva will aggravate the headache. So coughing, sneezing, increasing is not always ICP, even migraine headache. You can ask your friends who get migraine. When they cough and sneeze, does the headache worsen? It will worsen due to the Valsalva effect and altered hemodynamics in the intracranial compartment. So that is the only point you said it is favoring ICP. Of course, it can happen ICP even without ICP. So I feel that among this, if you take the bifrontal and nuchal pain, which is dull aching in nature, going on for so many years and every day, it is probably an infratentorial problem with a tentoriofrontal reference. That is the most probable possibility you can think. Otherwise, other causes, as I said, are very much less likely if you want to explain both neck pain and the frontal headache. Other kinds of headaches do not, various several types of headaches are there. All those headaches do not have this unique combination of neck and the frontal region. If it is short duration, you can think of even meningitis, because you can have a frontal reference directly due to associated inflamed sinuses, which can lead to one of the causes for meningitis is a chronic sinus inflammation. So frontal sinus also involved and patient develops neck stiffness, meningitis, that is possible. Then you can have subarachnoid hemorrhage. But all those things if it is of short duration. So because it is long duration, we have three typical causes where the neck and the frontal headache will come. And by exclusion using the odd features, we feel that probably it is a tentoriofrontal reference coming from an infratentorial pathology, the nature of which may not be very malignant. In that case, by this time, you expect a lot of other features which is not there. So some benign condition in the posterior fossa, like as you said, Dandy Walker cyst, arachnoid cyst, no? Arnold-Cherry malformation, and other benign cysts of the posterior fossa may be operated. Okay, so that is the discussion of this headache. How you exclude other headaches, that I always tell you, take the odd features, and soft features. All these patients have got some hard feature, that is frontal and nuchal. The soft features, I will think, is coughing, sneezing, aggravation. Odd features we picked up for every case, every cause. For the tension headache, for the migraine headache. And by using those odd features, we excluded, and now we think it is a. This I am telling, this is only a model. You tell a model symptom. Every symptom in your patient, you should make a template to analyze like that. So neurology becomes very easy. Okay. So this is probably a tendorio frontal reference headache of a benign lesion, either an arachnoid cyst or a dandy walker cyst or some benign cystic lesions of the posterior fossa is possible. Next. OTC means over the counter. Okay.
Yes, ma'am.
Then you said that 5 years ago, patient noticed swelling containing thick yellow liquid in between her middle and the ring fingers. That was the first symptom of the hand. Huh?
Yes, ma'am. So she noticed that she had an abscess, and while draining the abscess, they had not given her any anesthesia. And when they were draining, she did not feel any pain. That's how she realized that she has lost the pain sensation in the upper limbs.
Which
She
hand?
was able to.
Answer.
This was right hand, ma'am, initially. Because of that episode, that time only she tried to check her opposite limb also. She realized that there is no pain
What
sensation
is
at
the
all.
educational status?
So,
She
ma'am,
was
around the fourth standard.
But she'll be cooking and all, no? That time and all, she could appreciate. She
She
could.
had no, ma'am. That hot and cold sensation was preserved that time at this point in time. First, she noticed pain sensation, ma'am.
Okay, so what brought her pain loss to her notice is an abscess which could be drained without any anesthetic agent, indicates what? Her
That she has
threshold for tolerance is probably very high. She must have had the disability long back, total loss of pain, no?
Yes, ma'am.
She did not realize at all. So that
No,
is
ma'am.
very unfortunate. She is probably a poor lady who is having a very high threshold to tolerate disability. So I'm sure she must have lost it long back. She would have just brushed it off and never had an opportunity to meet any doctor. But she developed
Yes,
an abscess. That is something like a painless abscess, something
yes,
like a
ma'am.
trophic change.
Yes, ma'am.
It's like a trophic change. So when a trophic change becomes the manifestation of sensory loss, what term that we use for those patients? Many patients, they never know what is normal. You see, because we have normal, we know what is normal. When we never know what is normal, we don't know there is something beyond this, where you can appreciate even a small pinprick, that when it is lost, you realize it is abnormal. So these persons who never know what is normal, so this may be also very long duration. So
Yes.
she may be thinking everybody is like this only. Everybody's sensation is like this only. So that is what these people think. And so these kind of syndromes are called as acrodystrophic syndromes. So they present with the dystrophy. They present with loss of fingers, auto amputation, trophic changes, non-healing ulcers or abscesses like this. So these are called acrodystrophic syndrome. So at this point, your patient's second problem is an acrodystrophic syndrome. Definitely
Yes.
it must have been long back. So she never understood what is normal and she thought it is normal. And it was mainly for the pain sensation. And it was bilateral, both upper limbs.
Yes. Yes, ma'am.
So can you name some acrodystrophic syndromes? Acrodystrophy, I'm sure all of us have seen. Even though it is not very common these days, acrodystrophy as a presentation, Hansen's disease. No, very common. So this group of disorders, which are identified by the dystrophy, indicates the loss of pain is very long duration. They forgot to know what is normal. So when the dystrophy comes, it is brought to the notice of everyone. Under this, you have got inherited conditions and acquired conditions. Acquired condition, you should not miss at all. That is why I thought you should tell about Hansen's disease. Second, you have got porphyria cutanea tada. You have heard?
Yes, ma'am.
Porphyria, no? So, metabolic disorders like porphyria, amyloidosis, Tangiers disease, no? So, these
Yes.
are all small fiber involving neuropathies. So, porphyria, amyloidosis, Tangiers disease, these all involve the short axons. So, they spare the lower limbs and affect the upper limbs. And long after the upper limb is affected, only it goes to the lower limbs. So, these are called short axonal neuropathies. Whereas in Hansen's disease, it is mononeuritis multiplex, but it affects the cool part. So the ulnar nerve, that kind of nerves which are upper limb nerves are getting affected early because of the openness of the arms to temperature variation. That becomes a common situation for the organism to multiply. That is why Hansen's also usually early symptom is upper limb, even though it can be face, lower limb and all those things. Second is the short axonal neuropathies, as I told, porphyria. Then you have got amyloidosis and Tangiers. And then you have got inherited short axonal neuropathies. These are also inherited, but inherited non-metabolic, degenerative. What are these hereditary sensory neuropathies you heard of?
Yes, ma'am.
Inherited neuropathy.
Sure.
Yes. You have got
CMT.
CMT is motor sensory. It's a mixed motor sensory. Whereas hereditary sensory neuropathies are there. Under that, you have got Marwan's type, Denny Brown's type. You have got hereditary insensitivity to pain and hereditary sensory autonomic neuropathies. Now, their modified classification includes genetics and histopathology. This is a bedside classification. The research classification is there that puts the gene loci, genetic loci, and also the histopathological changes included. But for the bedside, Marwan's type is a short axonal type of hereditary sensory neuropathy, where it involves the upper limbs and sometimes the face. Purely sensory. So they present with the trophic ulcers. They put their hand into hot milk, hot water, not knowing the temperature. So that is Marwan's type. So it could be a Marwan's type of hereditary sensory neuropathy. Then you have got, what is Denny Brown type? Denny Brown type is both upper limbs and lower limbs. So hereditary sensory neuropathy, Marwan is only upper limb. Upper limb and lower limb is Denny Brown type. Hereditary insensitivity to pain, otherwise called human pin cushions. You see? Because they do not appreciate pain anywhere, including the scalp. So they can be used as pin cushions, people say. It's a very sad situation, very less common. I have myself seen only one patient in my lifetime. That was a child. When the child developed teeth, she bit her tongue. Your tongue, face, everywhere, and there is no sensation. She bit her tongue and she was brought to the hospital with a swollen tongue. Small child, 8 months or something, cannot tell whether there is pain or not. So the pediatric surgeon thought that it is a macroglossia because the tongue is big, the child is biting like that, and they did a partial glossectomy. That is a very big tragedy. Following the partial glossectomy, the child came with a split lip. Then the surgeon woke up and what is this? I am not knowing. Then he referred to neurology. Then the family is telling for vaccination, nothing, the child will cry. So the child died by about 2 or 3 years. They develop auto amputation of various limbs and they die because pain is protective. So that is hereditary insensitivity to pain, otherwise called human pincushions. And type 4 is hereditary sensory autonomic neuropathies. They have got sensory loss and autonomic dysfunction. Because of this autonomic dysfunction, they are not homeothermic, they are phyclothermic. So during summer season, they go and stand in the tap. Only by using this kind of external temperature modifiers, they can do thermoregulation. Natural thermoregulation doesn't happen. So family will think this boy is very naughty, always standing under the tap. They will stand, if they don't stand under the tap, they will cook themselves inside because of failure of thermoregulation. That is hereditary autonomic neuropathy. This can be partial or complete. Complete syndromes, very, very difficult. They should be shifted to throughout the year cold areas, like hill stations. Otherwise, they will not survive. There are now water cooler jackets where you can wear a jacket in which continuously cold water will circulate and keep your body temperature like that. So those things are very expensive, and you will have to keep changing with the change of size, and it is not possible for all human beings. So that is hereditary autonomic. So the next short axonal neuropathy you will consider as a possibility for this acrodystrophic syndrome. Then you have got Syringomyelias and pseudosyringomyelias. So Syringomyelia is, of course, crossing spinothalamic tract of the C8 D1 territory is the commonest territory. It from there it can expand and it can be multiple syringes. So that is very much a possibility. Because you already, if you want to link that neck pain and think some kind of craniovertebral anomaly with or without some posterior fossa pathology and an associated syringe is very much possible. And what is pseudosyringomyelias? Pseudosyringomyelias are intrinsic cord tumors, intramedullary tumors or intramedullary vascular malformations. That is Mallis type 3 dural AV fistulas. That is intramedullary AV fistulas are there. Type 1 is glomus, second is long dorsal, third is juvenile, fourth is intramedullary. So glomus presents like a compressive myelopathy. Long dorsal ones will present with multiple bleeds in multiple locations. Juvenile one will have both intrinsic spinal cord location and a subdural location. So they will have myelopathies and radiculopathies which are patchy. And intramedullary will present like an acute syringomyelia. Every time it bleeds, it produces symptom. When you examine, if you don't know the history, you will think it is a chronic syringomyelia. But they don't know, it is only yesterday when I had the severe neck pain, and following that this phenomena has happened. And later, periodically they get recurrence. Then, it's a recurrent bleed in an intramedullary avium. That is intramedullary aviums is present like a pseudosyringomyelias. Then you have got also neck pain patient. Pure bony anomalies of the neck can also produce a syringomyelic syndrome, which is also called pseudosyringomyelia. Why it is called pseudosyringomyelia? So we have probably a CVJ problem, which we are thinking of. And it can produce pseudosyringomyelia by associated cervical canal narrowing and sulcocommissural artery ischemia. The spinal cord is supplied by end arteries. So many end arteries. You have got the antispinal artery, you have got the postspinal artery. And they are connected transversely and vertically by varying reinforcing arteries. Vertically, you know that after C4, there is no antispinal artery, there is no postspinal artery. There are only reinforcing arteries. These reinforcing arteries come from the thyrocervical trunk, intercostal arteries, lumbar arteries. They reinforce the territory of the antispinal artery and the postspinal artery. Transverse plane, you have got end arteries, which are called sulcocommissural arteries. These arteries end in specific structures. When there are three vital sulcocommissural arteries, one which supplies the medial pyramidal fiber, second one which supplies the anterior horn cell, And third one, which supplies the crossing spinothalamic. So when the sulcocommissural artery, which are end arteries, are compressed from outside, either due to a degenerative bone disease, any kind of osteodysplastic disorder, which can affect young people, and or disc disease also in old people, older persons, they and that compressing pathology compresses the end arteries. If it compresses the end artery, which supplies the medial pyramidal fiber, you get the classical Ellsberg phenomenon. In the pyramidal fiber, the lamination is upper limb fibers are medial.
Yes.
And the sacral fibers are lateral. The sulcocommissural artery, which supplies the medial pyramidal fiber, is infarcted, means they get weakness in the upper motor neuron type of weakness in the ipsilateral upper limb. Then it spreads to the ipsilateral lower limb, then contralateral lower limb and contralateral upper limb. That's Ellsberg phenomenon. So if that is affected, Ellsberg phenomena will come. Supposing the sulcocommissural artery, which supplies the anterior horn cell, becomes affected, you will get muscle wasting. So it will resemble motor neuron disease. Supposing the sulcocommissural artery, which supplies the crossing spinothalamic fibers, are affected, it will present like a syrinx. But when you investigate, you will not find a syrinx. Instead, some signal changes. That is called pseudo-syringomyelia of cervical compressive pathology. So at the end of your this wound and never knowing that there was a pain, it's a very chronic acrodystrophic syndrome. The differential diagnosis will be hereditary, Marwan's type of hereditary neuropathy, and you have got amyloidosis, Stanges disease, porphyria, Hansen's disease, Syringomyelia, pseudo-syringomyelia. All these are the differential diagnosis. The category is acrodystrophic short axonal syndrome at this point of time. Later, she developed weakness of legs, I think, no?
Yes.
Okay. So she was unable to get up from the sitting posture, you told, no?
Yes.
So,
for the headache, at that time, she went to a neurologist, and she was operated, and thin pipe-like structure was connected from head into the abdomen. In 2020, she developed difficulty to lift the utensils from the stove or on the table. She was having difficulty to comb her hair by herself. But she didn't have a difficulty to grip the comb or vessel with her fingertips. That time she was able to perceive hot and cold sensation in the upper limb. And she was able to perceive all the sensations in the lower limb, trunk and back.
So what was the difficulty in
Ma'am, it was more like a proximal weakness.
Did she really have weakness or she had loss of sensation, therefore she could not hold?
No, ma'am, it was weakness because she told that she can't do overhead abduction, or if the vessel is heavy, she cannot lift like this using her arm muscles. But if there's any object,
can't she grip it? Could
she can grip it. She could grip it, ma'am.
Okay.
She can grip it, but she cannot lift it. So that was her complaint 3 years back.
Distal pain and proximal motor. Distal sensory and proximal motor.
Yes, ma'am.
So abducting is which muscle?
First 15 degrees supraspinatus, then 15 to 90 deltoid, and overhead abduction trapezius.
So if she was she able to initiate the first 30 degrees? Throughout it was weak. Was it weak throughout? Maybe. So if it was weak throughout overhead abduction, you will be able to understand whether it was there or not only if the patient had attempted holding the first 90 degrees and then tried to abduct. So whether the trapezius was affected or not, we cannot tell only if the patient's initial range itself is affected. Unless they have made an attempt to hold up to 90 degrees and then lift it. If they have not attempted, we cannot commit on that. So probably C5 root. C5 root innervated muscles. Is it a root level or muscle level? All those questions are there, but considering a patient who is having a phenomena like this, we are thinking that something is wrong with the cervical region. So the nerve root may be getting entangled. So probably it is a C5 root because supraspinatus is C5, deltoid is C5. Only triceps is coming from the spinal accessory. That part we don't know now. Even that can be affected if the lesion is a long region involving the accessory nerve also, we don't know. But we are not able to commit for that because we don't know whether the patient tried to lift it, supporting up to 90 degrees. So now there is a motor radiculopathy and a distal acrodystrophy. Small fiber. Okay, next.
1 year after that, she developed inability to perceive hot and cold temperature. She got to know this when she accidentally spilled hot coffee while drinking the hot coffee. And she did not feel any burning sensation on her upper limb. But when it spilled over to her lower limb, that time she realized it's very hot. And by that time, the upper limb had developed small areas of burns. Initially, this hot and cold temperature pathology was in the fingertips and it progressed to the forearm. And it now currently it extends up to few centimeters above the elbows. And both sides were equally affected and affected at the same time. She has caused multiple burn injuries to her, especially right hand, while cooking and drinking coffee. Now she requires her mother to cool the food before she can drink it.
So what disease gets this pain fibers involved early? What diseases get involved the temperature fibers early? Can you name one condition where the temperature fibers become affected early?
Leprosy.
Very good, very good. So that is probably the only condition where the temperature fibers become affected very early. And that too, cold temperature becomes affected early and then the heat becomes affected. Whereas pain becomes affected very commonly. It can be because in the crossing spinothalamic tract also there is a lamination where closer to the cord you have got the pain fiber and away from the cord you have got the temperature fiber. So by that lamination, whichever comes closer to the central canal becomes affected. Otherwise, you have got toxic neuropathies, vasculitic neuropathies. So you have got chemotherapy for malignancy. It is not a motor neuropathy. It is a sensory neuropathy where the pain fibers. And next is vasculitis. They involve pain and autonomic. So pain early is quite common, not only due to intrinsic cord disease, even due to peripheral nerve diseases, whereas temperature is very unique, and that is for Hansen's disease. That is very good answer. So our patient got pain first, and now the temperature is getting involved. That indicates extension of lesion in the transverse plane. Okay, next.
In the same year, after few weeks, she had inability to perceive the clothes and bangles over her forearm. And initially, she could not feel the bangles when she's putting the bangles into the forearm. And subsequently, throughout the journey of the bangles, she is not able to perceive. That symptom also is present up to the same level as the loss of hot and cold temperature, ma'am. Up to few centimeter above the elbows, and that is also equally affected on both sides and at the same time, and no such similar complaints in the rest of the body.
That means touch sensation is also getting involved
Affected.
slowly. So touch has got a double pathway, you know.
Yes, ma'am.
Touch fibers travel through the spinothalamic pathway as well as through the posterior. So completion of lesion in the spinothalamic tract may explain the same distribution. Supposing I say that even if you have an intrinsic cord lesion like a Syringomyelia, something like that in this case where you have neck pain and all those things, when the central cavity expands, it will compress on the posterior column. But I am not thinking like that in this case. If it is posterior column involvement, one thing you may have irritative features of posterior column like Lermit sign.
Yes.
because it is in the neck region. You may have girdle sensation, which is also an irritative feature of posterior column. Both are not there. Second, when the posterior column is involved, at that level, if the touch fiber is affected, it will not be suspended.
Yes.
It will involve the lower limbs and the upper limbs. So in your case, you said that it is only involving the regions where the pain and temperature is gone. So it is again only completion of the spinothalamic structures and not due to posterior column if it is an intrinsic cord pathology. If it is in a peripheral nerve pathology, we have discussed many peripheral nerve conditions which can present like this, acrodystrophic neuropathies. So if it is a peripheral neuropathy due to Hansen's disease or amyloidosis or tangiers, all those things we thought about, they also can complete the lesion at the peripheral nerve level. So only at 2 level, this kind of suspended complete sensations can be affected. One is the short axonal neuropathy. Second is the intrinsic cord pathology. Intrinsic cord pathology, where pathology is not involving the posterior column. It is only completing its involvement of the spinothalamic, and the touch fibers which are traveling in the spinothalamic tract is getting involved. Touch has double pathway. All of you know that. So either the involvement of touch again indicates either it is many of the short axonal neuropathies which we thought as a possibility, plus only ventral extension of a central canal problem, not dorsal extension.
Yes.
It is a central canal problem. Okay, next.
Next year, she noticed that her fingers are bending and her hands are becoming thinner. However, with the pressure from the opposite elbow, she was able to straighten the fingers partially. But otherwise, the fingers were in a deformed position, ma'am. There was thickening of skin over those bent joints. And because of the bending of these fingers, she was not able to hold any objects or food. And she used to use her palm to grasp objects, ma'am. So even when she's having food, she has to hold the spoon using the palm rather than the fingers.
So
she was not able to make a bolus of food.
So what do you call that? So she lost her precision grip.
Yes.
And she is having her power grip. So precision grip was lost. So she has to hold her objects like the way we use for a power grip. That is the terminology. So precision grip is by the short muscles. Yes. Whereas power grip is by the long muscles. So apparently this means that she lost her small muscles.
Yes, ma'am.
So, and if all the fingers became bent, it is called as what? Complete clawing. Complete. If only 1 or 2 fingers are clawed, it is called partial clawing.
Partial clawing.
It is not the completeness of the clawing that we call like that. If all the fingers are clawed, it is complete clawing. If only few fingers are clawed, it is called partial clawing. So apparently from the way she had been using her hand, her precision grip was lost, her power grip is retained, and probably it is producing complete clawing and involving all fingers, indicating that all the small muscles got affected. And all these small muscles are getting their supply from which segment?
C8, T1.
C8D1. If it is inside the cord, it is C8D1 segment. Or it can be a part of involvement of a length-dependent involvement in the upper limb of the short axons. So again, we are not ruling the peripheral nerve component because that can also explain all these phenomena. So it can be peripheral where they started in the sensory and went on to the motor. And all these neuropathies, even the short axonal ones, prefer only the distal muscles.
Yes.
So that is one possibility. Second, the central lesion extending to the more towards the anterior horn cell. From the medial to the lateral, they are going to the anterior horn cell, so that can be involving the anterior horn cell at the CAD1. So that is the possibility with the second symptom. Okay, next.
She at that point, she developed difficulty to get up from squatting position. She used to use both her upper limbs and a wall behind to support herself while trying to stand. She has fallen down several times as her elbows and knees would buckle under the weight. And she had no history of difficulty to turn around in bed. She can walk without support, but once the difficulty is in getting up from the squatting position. Once she got up, there was no difficulty in walking over an uneven road or gripping her footwear. She had a proximal weakness of lower limb with the relatively distal was spared, ma'am.
So why did you think her distal is spared?
Because the finer activities of lower limb like gripping footwear or walking over an uneven surface, these require arch of foot and coordination of smaller muscles. So those are relatively the distal part
Toe grip
that
is
is
impact.
spared.
So you think that the small muscles of the feet were not affected? Okay,
Yes, ma'am.
great. You said that once she gets up, she can walk.
Yes, ma'am.
And so what does that indicate? She was not walking, standing on her bones. You see, if the patient is standing on the bones, they can get up and stand. When there is severe proximal weakness, somebody helps them, they will get up and stand, locking the tibia and the femur and the cruciate ligaments. But they cannot walk. They cannot walk on their bones. So she's walking. But you said that when she starts walking, she's okay.
Yes.
Will it be possible with the proximal muscle weakness?
No.
What will be the way the patient will get up when there is a proximal muscle weakness?
Goer sign will be.
Yes, something like that. Some hip up sign, hip dip, badly.
Yes.
All those things will be there. If there's that much proximal muscle weakness that the patient is falling several times. No? So, but able to walk is not at all practical. A patient who has got a weakness that makes the patient fall several times. They cannot walk normally. They may be able to walk, but they will walk with a waddle and they will get up like so many phenomena which indicate a proximal weakness, and they will have Trendelenburg effect like dipping of the hip. So none of those things are there. So that means probably what is making her get up from the sitting position is loss of kinetic melody. What we call kinetic melody, for any motor activity, you have to facilitate the agonist, suppress the antagonist, and correct erroneous movement.
Yes.
It is happening by the motor control loops. Motor control loop, cerebellum, basal ganglia, motor cortex, they are all involved in the motor planning. So from the cortex, corticospinal, then basal ganglia, cerebellum, along with the area 4, area 6, they make the motor plan. This plan is upper motor neuron. That is facilitate agonist, suppress antagonist, correct erroneous movement. So when this fails, patient will not show features of muscle weakness like hip up sign, waddling, or Trendelenburg effect. Nothing will be there, but they may walk for some time. So suddenly all the agonist and antagonist will be simultaneously facilitated. Normally agonist is facilitated, antagonist is inhibited. So when the melody of the motor movement plan fails, agonist and antagonist can become simultaneously activated. So it will simultaneously contract, simultaneously relax. When it simultaneously relaxes, patient will buckle and fall. When it simultaneously contracts, he will walk, but he'll walk with a stiff leg. So that is that will not show the features of a proximal muscle weakness. So it is likely, but we need more information about the semiology of the walking to say whether it was a loss of kinetic melody, because you said that when she's walking, she's able to walk, but she is falling several times with buckling. So walking without gross alteration in the semiology is not possible when there is a severe proximal muscle weakness. But if it's a kinetic melody is lost As long as there is no core relaxation, they will walk. But some degree of dragging and stiffness will be seen. That you will have to see to demonstrate. So I feel that it may not be proximal muscle. It may be kinetic melody loss. So there is probably co-contraction and co-relaxation. And during the period of pro-relaxation, she may be buckling. That you interpret by associated stiffness and absence of features of muscle weakness, like waddling. That you'll have to examine. She may not be able to tell. Okay, next.
She complains of swaying to the left side while walking. She feels that there is a dragging sensation, something that drags her towards the left side, which makes her take steps towards the left side. There is no history of specifically falling on the left side, or there's no history of peripheral vertigo symptoms, tinnitus, or hearing loss, ma'am. There is no other history suggestive of incoordination or clumsiness.
Truncal ataxia.
Yes, ma'am.
Degree of truncal sway.
Yes, ma'am.
So as you said, swaying to one side can happen in vestibular problems. In that situation, patient will experience other vestibular symptoms like vertigo, vomiting. Those things are not there. So it may be it can be happening in the flocculonodular lobe, where unless the vestibular afferents and the vestibular nucleus or the inferior cerebellar peduncle, which comes into the flocculonodular lobe, is affected, other vestibular symptoms need not be there. So it is a unilateral trunk swaying, very unlikely to be due to the extra axial part of the vestibular component, because there is no other vestibular symptom. So it can be the central vestibular control, which comes from the flocculonodular lobe or the archicerebellum. That is one possibility. Other possibilities, you can have swaying which is due to probably associated stiffness and proprioceptive loss. Whether she drags and she describes it as swaying, we don't know. If she's really swaying and that swaying to one side without vestibular symptom, you have to think of a asymmetrical lesion, asymmetrical syndrome involving the flocculonodular lobe. So if it is neocerebellum, it will be upper limb incoordination. If it is paleocerebellum, it is bilateral gait imbalance. If it is dragging to one side, it has to be flocculonodular lobe. So probably flocculonodular lobe by exclusion of other vestibular symptoms. But a vestibular phenomena complicating the gait without the features of vestibular nucleus involvement. So most probably her flocculonodular lobe is involved in some way in this situation. Okay,
then she developed history
that
of passing.
Not have a speech component, that does not have a upper limb component. That all explains flocculonodular lobe only. Neocerebellum upper limb component will be there, speech component will be there. Paleocerebellum, as I said, bilateral gentle swaying, not unilateral. And whereas this flocculonodular lobe can't produce a nystagmus due to vestibular connection involvement, that when you examine, you might look for. Okay.
Yes, ma'am. Then next she developed history of passing a small quantity of urine, around 10 to 12 episodes per day, which she describes that often she had loss of control and she would be able to feel the filling of bladder, but within by the time she goes to the restroom, she has already passed it in her clothes.
Is having some kind of bladder sensation.
Yes, ma'am.
That is there. But she is having precipitancy.
Yes, ma'am.
And and she has frequency.
Yes,
precipitancy and frequency, no?
Yes,
so she doesn't have any dysuria, I said. So it is very unlikely to be due to a urological cause.
Yes, ma'am.
But precipitancy indicates what? Apparently partly preserved. Sensations are normal. Precipitancy indicates inhibitory fibers. From the cortex, you have got inhibitory fibers, you have got facilitatory fibers. Both descend as the bladder fiber close to the corticospinal tract. If the inhibitory fiber is involved, you get precipitancy. If the facilitatory fiber is involved, you get hesitancy. If both are involved, you get automatic bladder. So in this patient, it's a partial involvement of the bladder fibers traveling so that there is precipitancy. That precipitancy because the inhibitory fibers are probably involved in this patient. Second, she is having frequency without dysuria. That means poor storage.
Yes.
So poor storage. Storage happens by what?
The relaxation of detrusor and contraction of urethral sphincters.
Which one is carrying out that? Sympathetics.
Sympathetic, yes.
So she is having a partial involvement of the inhibitory fibers and the sympathetics.
Yes.
That is why poor storage. Otherwise, you can have also frequent bladders commonly seen in urological problems like dysuria. All those things will be additionally there, means beneficial. Intravesical tumors, contracted bladder due to chronic catheterization. They are all urological causes. Second situation where you get a poor storage is a Barrington center, Parkinsonism, where the bladder capacity is around 700 ml. Beyond that, it has to take the cortical permission. So, yeah, Parkinson patients also have poor storage due to Barrington center. So, sympathetic involvement and Barrington center involvement are neurological causes for poor storage. So, in this patient, probably she has a sympathetic involvement because something is happening in the upper cervical cord, as a lot of evidence we already got. And that may be involving the autonomic structures as well as the, it may be involving the craniovertebral descending structures. So that will explain most of her symptoms. So probably she has got a sympathetic and inhibitory fiber involvement that explains the bladder symptom. Bowel usage, she is constipated, either with lemon or UMN. Usually, bowel doesn't have a characteristic presentation. Both lemon and UMN, bowel presents as constipation only. So you make the diagnosis based on the bladder symptom rather than the bowel symptom.
Bowel symptom, yes.
Yeah. So that we will take it soft one.
Yes, she did not have any history of emotional disturbance, behavioral changes, or seizures. No history suggestive of any other cranial nerve dysfunction. No history of twitching of muscles. No history of paresthesias. No history of swelling of joints. No history of similar complaints in the family members. I had drawn a pedigree chart, but it's not.
Her upper limb, the joints have no pain, no?
No pain sensation, and there is no swelling of the joints, ma'am. It is only thickening of the...
not necessarily swelling.
Yes,
it's a destroyed joint. So supposing you take hinge joints, no? Most of the joints in the fingers are bidirectional movement. They are hinge joints.
Yes.
They show a movement in more than their bidirection. Then you call it as neuropathic joints. Swelling can be there, need not be there. So do they show movement in planes other than their usual planes? If that is called as Charcot joints. Okay. Then
in the past history, she was firstborn of
the pedigree chart, no? Where is the pedigree?
Ma'am, it is not getting displayed in this. There is no other family member with similar complaints.
Okay.
She was firstborn out of a non-consanguineous marriage. She was born at preterm, 7 months, at home via vaginal delivery. There was no history of any hospitalization or childhood history of any other neurological dysfunction.
Why was she preterm?
Ma'am, she doesn't recall. Her mother also doesn't recall any infection or anything at that point. She said that the membranes had ruptured, so some traditional dye worker came and did a home delivery.
Okay.
Probable diagnosis at the level of history would be query hydrocephalus, because she had a history of shunt being placed, and patchy suspended sensory loss, proximal upper limb weakness, and proximal lower limb weakness, and UMN bladder, which made me think of an intramedullary lesion at high cervical cord.
Yes. Now we are negating the short axonal neuropathy based on what features?
One hydrocephalus, if we want to associate the two
Maybe, no,
symptoms.
yes. Shunt was placed, how much was the hydrocephalus and all? We don't know. Because ICP, classical ICP features were not there in the history. It was a dull aching, long duration headache. So most important feature we say that it is not a short axonal neuropathy is the upper motor neuron features she got in the lower limbs.
Yes.
Like a poor storage bladder and buckling without weakness, buckling without proximal weakness. So that indicates that the long tracts are getting involved. Corticospinal tracts. That is the one which is peripherally carrying the kinetic melody. So that indicates whatever the pathology in the cervical region is more than a nerve. So what is the closest point that you can put it in the crossing spinothalamic tract and the nearby ventral horns? That will explain the wasting and the dissociated anesthesia. And probably usual associations like Arnold-Chiari might have been there, and that is producing unilateral swaying. The swaying to one side may be due to probably additional Arnold-Chiari, and she might have had a posterior fossa lesion, and maybe that plus minus hydrocephalus might have been there, because when you have a Dandy Walker cyst or any posterior fossa cyst, you can produce a mass effect on the fourth ventricle, and that can produce a hydrocephalus, even though the classical history of ICP we did not get from the history. Whether she had it and she didn't tell, we don't know. Okay, next. Yes, Arnold-Chiari malformation because of the swaying to one side.
Yes.
Okay.
Coming to examine.
After completion of your history, the element problems, infective neuropathies, all of them become negated. And it now looks like a cord pathology. Cord pathology, both probably extramedullary, extradural plus intradural. Why extramedullary, extradural? Because you said she has neck pain and painful neck movements. That cannot happen in a pure intramedullary pathology. So at the end of history, you will tell that your examiner, all these possibilities I thought, because now my patient is developing cord signs, and now my patient is developing some signs referable to the flocculonodular lobe. I will cut off all the small fiber neuropathies which I was considering. So it's a cord plus hindbrain plus syndrome. But most of the features are explained by an intrinsic cord disease, but she has painful limitation of neck movement and neck pain. So it is probably a combination of extradural extramedullary plus intramedullary pathology, which is producing problem in this patient. So at this point of time, as an MD student, quickly tell me what are all the features of an extramedullary extradural?
Extramedullary extradural usually has a root pain. It is asymmetrical. It has
extramedullary extradural is asymmetrical or symmetrical?
Ma'am, classical example would be disc bulge, disc prolapse. Usually asymmetrical.
Now, myelopathy is usually symmetrical in extramedullary extradural because it is the cord from the vertebra. Whereas asymmetry, typical asymmetry is neurofibromas, meningiomas. They are intradural lesions. Because rarely you get a neurofibroma which arises from the both C5 roots simultaneously.
Yes.
Or even a meningioma for that matter. They are always asymmetrical. So extramedullary extradural lesions, one must first point you will tell painful movement of joints at whatever level it is. That is never seen in Intradural or
Intram
intramedullary.
medullary.
Then what will be the pain in intradural? Yeah, pain in
Bone.
intradural will be root pains of the root in which the neurofibroma or the meningioma is situated. But when you examine the root signs, may be less.
Yes.
Root pains are more, no, root signs are less. Because the tumors are usually small, they lie in a large space, they move about. So when you examine, you might not find a reflex loss or sensory loss, but patient will get episodically root pain. That is typical intradural. Whereas extradural extramedullary is a joint movement pain. They can have gibbous, they can have local tenderness, with or without root pain if the intervertebral foramen is also involved in the process. If the intervertebral foramen which contains the root is getting involved in whatever pathology, they will have root pains. Whereas root pains are more common in intradural. Root signs are more common in extradural. Extradural. Because the root, if it is involved, it is in the foramen. There is not much space. Whereas intradural, there is space. So when the tumor moves and drags, the patient will get a flashing pain. But it moves away, so it doesn't produce a sign. Whereas extradural, it gets compressed in the foramen. It has no space to move. So signs are early. You just close your eyes and think of the senior citizens who come with the cervical spondylosis. They may tell some neck pain and all. Well, they may never tell you about a root pain, but when you examine, you find usually a bicep jerk is absent or depressed. So root signs are more common in extramedullary, extradural. Intradural is root pains are more common, root signs are less common. Asymmetry is more common intradural, symmetry is more common extradural. Then gibbous tenderness. They are definite features of extra. Yes. Whereas in intradural, extramedullary, there can be segmental muscle wasting. So in that segment, there can be a small scoliosis from the root in which the neurofibroma is coming. The muscle supplied to the paraspinal muscle also comes from there. So that segment of the paraspinal muscle becomes wasted and you get a scoliosis. At the small scoliosis, as the disease advances, it can become big. Then you get late
bladder and bowel.
Yes, in both these conditions. And of course, investigations, X-rays will show vertebral pathology or disc pathology, lytic lesions. And whereas in intradural, you find intravertebral foramen scalloping. Because the neurofibromas produces scalloping semilunar sign. And of course, MRI will clearly show. Olden days, it used to be myelogram. Now it is MRI will clearly show the location. Brush border block in the myelogram is extradural, extramedullary. Intradural will be cup and the cap sign. So if a neurofibroma is like this. So I put a dye from below, it will produce a cup. Dye from above, it will produce a cap. So it is called cup and the cap sign. But nowadays we are not doing because they are all invasive. So you will find the shape, you will find the location, you will find the contrast enhancement, everything with the imaging, plane and contrast. Whereas intramedullary lesions, what will be the nature of the pain? There is no gibbous, there is no movement restrictions, there is no tenderness. Your patient has got movement restriction and pain as a very early symptom. That is why we are thinking of a combined pathology. Whereas pure intramedullary lesions, they produce tract pains. So it will be superficial burning paresthesia. Or it will be superficial feeling of heat or cold. It will not produce root pains or movement restrictions and all do not happen. So our patient, sometimes she experienced some burning pain? Huh?
No, ma'am.
So intramedullary lesions produce tract pain coming from the spinothalamic tract. And as the intramedullary lesion expands, it produces posterior column tract pains like Lermit sign. Both are not there in our patient. Okay, that can happen if it is identified very late when the sensation is completely gone. You may not know that. Second, they produce suspended dissociated anesthesia.
Yes.
Whereas other lesions, they produce sensory
In the
loss,
distribution of
of roots,
roots.
and when it compresses the cord, it is the long tracts. Whereas here it is suspended and dissociated. Because it is suspended and dissociated, unlike the extradural compression, this sensory impairment, as the disease advances, will descend. It starts above and descends. Whereas other conditions, it becomes symptomatic below and ascends.
Yes.
And because these intrinsic cord lesions are central, they produce early bladder.
Yes.
So you have got neck movement restriction, neck pain, and a late bladder. So all these can be attributed to a extramedullary lesion, and she has also a C5 root. Lifting of the arm is difficult. And the dissociated anesthesia, suspended anesthesia, all that can be explained by only by an intrinsic pathology. So she has a combination of intrinsic and extrinsic in the high cervical cord. Plus, she probably has got an ulnar cherry malformation, plus or minus hydrocephalus. Okay. Then examination it.
We have a middle-aged female patient, moderately built and nourished. Her height is 171. BMI is 20.86. Short. She has a short neck. Neck length is 8 centimeters. Height neck ratio is 21.37. She had no winging of scapula, no
home delivery,
neurocutaneous.
no? Whether she they produced an acute CV junction problem also. Power. Okay, home delivery, no?
Yes.
Okay.
No neurocutaneous markers, no markers of nutritional deficiency, no evidence of swollen painless joints. Ma'am, clubbing because of the deformity could not comment.
Okay.
But it did not look like clubbing.
Clubbing means you should say the deformity of the nails along with increased pulsations in the nail bed. So, does he have increased nail bed pulsation? That's an essential component of clubbing. Otherwise, don't bother about that.
Yes. Vital parameters are all normal. There is no significant BP variation between the upper limb and lower limb and in the supine and standing position. And respiratory rate is normal, 16 beats per minute, 16 cycles per minute, and it's thoraco-abdominal. She was afebrile. In the neurological examination.
Respiration in the female?
Thoraco-abdominal.
Good.
Yes. Higher mental functions are normal. Cranial nerves, there's no evidence of nystagmus, ophthalmoplegia, dysphagia, hoarseness of voice. Gag reflex was preserved. So there's no evidence of cranial nerve dysfunction. In the motor system, nutrition and bulk, ma'am, there was no history of, on examination, there was no asymmetry in bilateral upper and lower limbs, but on visualization, she looked wasted compared to a normal person. But both sides are equally wasted, ma'am. So there was no asymmetry as such.
But it is definitely wasting.
It is definitely wasting.
What is the difference between wasting and thinning?
Fasciculations will be present in wasting. Thinning can be due to sarcopenia.
Supposing we have got some fever and you lose your weight. We become thin. We don't become wasted. That means loss of bulk with normal power. That is called thinning. Whereas loss of bulk with loss of power is wasting. So in this patient, even though generally she is relatively having a low BMI and other things, not relatively, absolutely she is having, she is a thin person, but in the hands there is loss of bulk and loss of power. So it is pathology, whereas thinning is not always pathological. Thinning may be in general conditions like nutritional or some kind of long rhythms, fasting, thyroid disorders, but not primarily a muscle or nerve disease. Whereas wasting is definitely a primary neurological problem. So you use the term wasting when there is bulk loss with power loss.
Yes, ma'am.
When there is bulk loss without power loss, it is called thinning. For thinning, there is a broad differential diagnosis. For wasting, the differential diagnosis is narrow. Okay, so it is definitely wasting.
Small muscles of her hands were wasted. There was evidence of complete clawing of both the upper limbs, but there was no asymmetry. On tone, right upper limb and left upper limb were both hypotonic. Both the lower limbs had normal tone. Muscle groups, ma'am, in the upper limb, shoulder abduction, adduction, she had a power of 3 on 5 bilaterally. Shoulder flexion, extension, internal and external rotation, 4 on 5 bilaterally. Elbow flexion, extension, wrist dorsiflexion, wrist palmar flexion, also 4 on 5 bilaterally. And hand grip was weak bilaterally. In the lower limb, hip adduction, hip abduction, flexion, extension, internal, external rotation are all 4 on 5 bilaterally. And knee flexion, extension, foot dorsiflexion, plantar flexion are all 4+ now.
Okay.
Reflexes, upper limb areflexia, biceps, triceps, and brachioradialis jerk, whereas lower limb had 3+ and ankle jerk also 3+. They were brisk, ma'am.
But there was that her buckling was due to
UMN
motor neuron involvement.
Yes, ma'am.
She was falling due to upper motor neuron involvement due to loss of motor melody.
Yes, ma'am. There was no clonus. And superficial reflexes, corneal, conjunctival, jaw jerk, these are all normal. Plantar reflex was extensor bilaterally. Hoffman sign and Wartenberg we could not elicit because of the hand was fully clawed. Sensory system examination, what I've marked is the area where it is lost, ma'am. This is for pain sensation. It is exactly lost in C6, C7, C8 areas, ma'am. And right from the beginning of the nerve root all the way till the tip of the finger. In this shoulder blade area also, she had loss of pain and pain as well as temperature, ma'am. Same distribution for both pain and temperature. For a fine touch, the involvement was a little more. It was starting from C5 itself. It extended up to C7. And vibration sense was also lost actually in C4 and till C7, C8. Even vibration sense was impaired, ma'am.
That is now, because there is already myelopathy also.
Yes, ma'am.
She has myelopathy, so the columns long
are also getting
involved.
Also getting affected. Yes, ma'am. Romberg sign, ma'am, this is for crude touch. Only distal part C6, C7, C8 was affected. That did not involve the shoulder blade area, ma'am. So Romberg sign was negative. Overall, the patient had a patchy sensory loss, cape-like distribution with suspended sensory loss.
At this point of time, definite dissociation is not there, but
yes,
it was definitely the last thing to get affected in the history.
Yes, ma'am. In cerebellar signs, patient is able to take a few steps to the left. When she is walking, she takes a few steps to the left, ma'am. Otherwise, the gait looks normal, ma'am. She does not have any, by history, what she told that she has buckling and she falls down. She did not have any such phenomena while examination. Definitely, she took help of a wall and 2 hands. She had to get up from supine, from squatting position. But once she started walking, the semiology looked normal, ma'am. I'm not sure if I missed anything, ma'am. Sorry.
No, doesn't matter. The video is there or no?
No, ma'am, video is not there. It was in a busy ward. She was not willing to lift up her clothing.
Definitely, she has a short neck.
Yes, ma'am.
So, short neck indicates what? There is some bony anomaly. Definitely.
Yes.
So, she has got a bony anomaly plus minus soft tissue anomaly in the high cervical region plus an intrinsic. After examination, the additional points we got is the definite evidence for the pyramidal tract involvement.
Yes, ma'am.
Which was not very evident except some indirect evidence of buckling without alteration of the gait semiology.
Yes.
So that is the additional feature. If you had the video, we can try to describe. Doesn't matter. You have the investigations you have with you.
I have, ma'am.
X-rays you can show. Huh?
I have, ma'am. I will show. Other systems were normal, ma'am. So my final diagnosis in neurological deficits, there is suspended sensory loss with cape-like distribution along predominantly C5 to C8 dermatomes. There is weakness of upper limb, predominantly proximal more than distal, with hypotonia and areflexia and small muscle wasting. In the lower limb, there is proximal more than distal weakness with hyperreflexia, extensor plantar reflex, and UMN type of bladder. Anatomically, this correlates to pyramidal tract, anterior horn cell, lateral spinothalamic tract, anterior spinothalamic tract, and posterior column. Pathology.
Column, you are not sure, no?
Ma'am?
Posterior column.
Only based on the vibration sense.
The lower limb.
Lower limb was normal, ma'am. Only upper limb.
Then you cannot call it as, because in the upper limb touch also is a double path, you know.
Yes, ma'am.
So how to differentiate posterior column from the proprioceptive fibers which travel along the spinothalamic? If the posterior column is involved, it will be a column pattern. So lower limb show rhombox, you said it is negative.
Yes,
you can look for joint position sense, vibration sense in the lower limbs. If that is also affected, you will call it as a column. Either irritative sign should be there. Both are not there. So as such, posterior column involvement, we don't have data. What we have is some degree of proprioceptive sensation in the upper limb, which can be because of the double pathway of these sensations.
Yes, ma'am.
The posterior column, you will cut it off. Okay, next.
Yes. Pathology, I felt it is degenerative because of the long history, ma'am. And to associate the history of VP shunting, I feel the etiology would be Syringomyelia and Arnold-Chiari malformation.
So it definitely indicates a bony CV junction anomaly.
Yes, ma'am.
With the soft tissue anomaly. Because bony anomaly as evidenced by short neck, which you clearly demonstrated. Whatever is the bony anomaly, we do not know. It may be clipper field anomaly or single cervical vertebra, or instead of 7 vertebra, 3 or 4, we don't know. But there is a bony anomaly, that is why short neck is there. Hemivertebra, clipper field, all these produce short neck. Or basal or invagination, platybasia, all of them will alter the neck length. So that you should mention. It is not a pure soft tissue condition. No? You only demonstrated.
Yes,
see a painful limitation of neck movement and short neck indicate there is a bony anomaly. So it's a bony plus soft tissue. And the soft tissue anomaly strongly supports the Syringomyelia. With or without complications of a high cervical Syringomyelia, which are Arnold-Chiari and hydrocephalus. But Arnold-Chiari, we apparently thought from the history that she is swaying to one side, but we did not find any strong evidence when we examined the patient. Yes. So, and hydrocephalus is indirect. You didn't find any post-papilledemic optic atrophy. You did not find any ICP headache. So we don't know. Maybe even a small hydrocephalus, somebody will shunt, all those things happens. So we have to see to believe that. So your primary diagnosis will be a combined CVG anomaly, bony plus soft tissue. Yes, sir. Plus or minus Arnold-Chiari and hydrocephalus. So you should not omit that bony anomaly, which you said from the beginning, no? Painful neck movement, neck pain, and short neck. So it's a combined CVG anomaly, which is a very hard features are there for bony change. Hard features are there for intramedullary changes. And Arnold-Chiari and hydrocephalus plus minus will put. Okay.
Yes.
Then show the investigations.
So, it is getting slow, ma'am. 1 second.
So no problem. I am seeing the images. Don't show the result. I want to see them.
No, ma'am. I clicked the next button a couple of
problem.
times. It is just a minute.
We'll start from the brain.
Yes, ma'am. It's coming very slowly. 1 second.
No problem.
I'll just go to that slide and share my screen once more, ma'am.
Yes. Okay. If you want to describe that brain imaging, there is a definite ventricular dilatation.
Yes, ma'am.
Even after the shunt has been put, the ventricular dilatation is persisting.
Yes, ma'am.
It is asymmetrical, and you find a third ventricle you are seeing, fourth ventricle is also you are seeing. They do not show that much dilatation like the lateral ventricles. So lateral ventricle is very much dilated. That is asymmetrical, including the temporal horn is asymmetrical, larger on the left side compared to the right side. But the
Yes.
fourth ventricle appears normal.
Yes.
So probably it's an obstructive hydrocephalus. And obstruction probably is in between the fourth ventricle and the lateral ventricle. That is the interpretation. Then sulcal spaces, I cannot say there is any migration disorders or any atrophy. I am not seeing. And in these pictures, I am not seeing the shunt tube. You saw the shunt tube, huh?
No, ma'am. In the X-ray, we can see the shunt, ma'am. This MRI, I was not able to find. This was the
Then
spine imaging.
Yes. Yeah, they are appearing very small images, but
I will trying to. I'll put the slideshow, ma'am. The image size is large, so the computer is
no problem.
slowing down.
This is the nodule. This is the
Yes,
nodule
ma'am.
of the flocculonodular lobe. You drew the foramen magnum is you have to you see is trace the posterior fossa.
Yes,
Come
ma'am.
land on the posterior lip of the foramen magnum. You slide
Yes.
along the clivus. You will land on the anterior lip of the foramen magnum. Clivus is posterior clinoid process you have to trace. This is the posterior clinoid process. Slide along that. This is the posterior lip of the foramen magnum. So you draw a line that is called Mbbs line. Draw
Yes,
the
ma'am.
posterior lip and the anterior lip, and the nodule is definitely below that.
Yes,
This is a
ma'am.
nodule.
Yeah.
And your Mbbs line is there, nodule is below that.
Yes,
So that's an Arnold theory where the nodulus of the flocculonodular lobe is sitting. And you have
Yes,
got a central cord widening, which is extending from C1 to D2, D3 region.
Yes, ma'am.
And in that area, the cord shadow is very thin.
Yes,
Cord is
ma'am.
atrophic.
Yes, ma'am.
Okay. So definitely, this is qualifying for an Arnold theory malformation with a Syringomyelia and a arrested hydrocephalus. And let us now look at the bony structures. Where is the atlantodental distance for which plain X-rays and CT will be superior than the MRI. This is the odontoid. I think this is the anterior arch of the atlas. Could you measure the distance? Odontoid appears hypoplastic to me. In this picture, I am not clearly seeing the anterior arch of the atlas. Then only you can measure the atlantodental distance. In an adult, if it is more than 3 millimeter, it is atlantoaxial dislocation. I am not able to see that because the anterior arch is not clear here. These spaces are normal. The vertebral
Yes.
bodies appear small in the cervical region. Compared to the
Yes, ma'am.
normal size, they appear small.
Yes.
Otherwise, I am not finding any clipal feel or any other anomaly.
Yes, ma'am.
But you take an X-ray and measure the atlantodental distance.
Yes, ma'am.
So now what you are going to do for this patient? She is already in an advanced end-stage disease. No?
Yes, ma'am.
Whatever she lost, she is not able, she is not going to get back.
No.
But what is remaining is her gait. The kammal.
This we can see.
Yes. But we should have removed her kammal, no? Studs. They are there, I think.
Yes.
No problem. So this is the odontoid. C2 is there. The odontoid and the C2, the space is demarcated. So they have not fused properly. Over the anterior arch of the atlas is there. I don't think there is any atlantoaxial dislocation. Yes, the distance apparently appears normal only.
Yes, ma'am.
I am not measuring, but apparently it looks like normal. But I think there is a dysplastic odontoid because it is
Yes, ma'am.
slightly tilted and the joint is now odontoid develops from three. One is the occipital meato, second is C1, third is C2 body. They fuse, but here it is not fused. You can see the line, fusion line. So fusion of the three components of C2 has not taken place. And it is slightly anteriorly tilted and looks dysplastic. But
Yes,
there is no atlantoaxial dislocation. I will call this as a dysplastic and a poorly fused odontoid, three segments. Odontoid C2 has a three components, odontoid. One is from the occipital meato, one is from C1 body, third is from C2. So they will fuse, but the joint line is still seen. Then this is the posterior lip of the foramen magnum. And this is the cella. This is a cella. But I am not seeing the clivus because the mastoid hair cells are overlapped on the clivus. X-ray, just as you say, the shunt tube you are seeing, has it slipped off? Because we saw, I didn't see it in the brain. So
this one, ma'am.
Shunt tube is there.
Yes, ma'am.
It is not seen in the brain MRI.
Yes, ma'am.
So whether after a long time, sometimes it can slip off. So you should see whether it is really in the space.
Yes, ma'am.
Second, any other anomaly, there appears to be a spina bifida here. Is it some artifact or what? Looks like that. The spine of the C2 shows a V shape.
This one, ma'am.
Here. That doesn't produce any compression, but indicates there is an anomaly there. Okay. That's all. Anything else?
Yes, ma'am. No, ma'am.
So what you will do for her now? You should try to preserve her gait.
Yes, ma'am.
So that's how you will do. That's all you can do for her to prevent progressive compression. So you have to do foramen magnum decompression, pull up the nodule. So two things, you should prevent progressive compression so that she will continue to walk like this at least. That's all. What is gone completely cannot be restored. So she can maintain her ambulation. That is done only by preventing progressive compression of the nodulus on the cervical cord and expansion of the syrinx. So what you will do, you have to do a foramen magnum decompression, pull up the nodule into the intracranial compartment, then close the foramen magnum. And you have to do a high cervical laminectomy so that the syrinx will expand, but it will not compress on the vertical spinal tract and posterior column. So that is what will be the treatment for her. She should not be sent home. She should walk. You should tell her you will not get her upper limbs. That is gone. But she can be maintained like this, ambulant. For this, a major surgery of foramen magnum widening with pulling up the nodule and fusing and high cervical laminectomy. Cervical laminectomy, not high cervical. to allow the cavity to expand if it wants, but it will not press on the tracts. That's it. If it is unilateral eccentric, you can do the syringothecal shunt and all, but it is in bilateral. So syringothecal shunt will not be useful. Instead, the cord will collapse and develop a hemorrhage. So we will do only a laminectomy. Any doubt? It's a straightforward case, but you have picked it up very nicely. And we went through symptom analysis, as I always do. Very good presentation for an MD student. You answered most of your questions very well. Good luck for you. Any questions you can ask me.
Ma'am, that UMN, the proximal muscle weakness of her lower limbs, that I couldn't really understand, because UMN features usually we expect a distal weakness rather than proximal. How do we explain the proximal?
No, it is not at all weakness. I didn't say any weakness. It is only the motor
melody,
schema,
which is
melody. Motor schema. It is a spastic buckling.
yes, yes.
If it is a muscle weakness, what all muscles will affect? Either quadriceps or gluteus maximus or gluteus medius and minimus. If it is gluteus maximus, you will get up with a hip up. Medius and minimus, you will waddle. And you will have hip dip. Quadriceps means you cannot walk at all like this. Quadriceps will not stabilize the knee if it is weak. So it is definitely not a muscle. And it is a stiff buckling. You have demonstrated a sign of a brisk jerk. That is after examination. Even before that, apparently normal semiology, but buckling attacks. And proximal, it is not proximal weakness, it's only buckling. No? So that indicates that, and semiology not altered. That is very typical of loss of motor melody.
Yes.
That, as I said, the agonist is facilitated, antagonist suppressed, erroneous movements corrected. That is not happening. So occasionally agonist, antagonist and synergist will contract together and they will relax together.
Yes.
When they relax together, patient will fall. It may not be happening all the time. You see, when you do a mistake, you don't do it all the time, no? When you do the motor plan, it's a motor plan. Kinetic melody means motor plan failure. Motor plan failure for an anticipated movement. Gait is an anticipated movement. Unanticipated movements, complex dancing movement, that mechanism are all different. This is an anticipated normal walking. There occasionally the motor plan fails. So when the motor plan fails, all of them contract. So briefly the patient will feel stiff. Following that, all of them will relax. So briefly, patient will buckle. Because the agonist, antagonist, everybody will totally relax and everybody will totally contract. So routine semiology, nothing will be altered.
Yes.
Any other question?
No. Thank you so much for your valuable time, ma'am.
No. Nice presentation. I like doing my job. If it helps you, I am very happy. And if we can treat one patient better, that is wonderful for me. So thank you so much. Very nice.
Thank you, ma'am. Thank you.